Thank you, Dr. Bearfield. Thank you for that kind introduction. I'll try to share my screen. Please let me know if it's okay. Can everybody see my screen?
Yes.
Okay, so I'll be talking about low ejection fraction coronary revascularization in this underserved population in the state of Washington and beyond. So just to talk, I'll be talking about some demographic parameters as well as evidence for a low ejection fraction coronary revascularization and its prognosis, as well as our unified, some of our designed unified protocolized approach for management of these patients, and our ambition in establishing a regional service for the Pacific Northwest and Alaska. Just to give you an idea as of the problem that coronary disease poses in the Western world, 5.8 million in the United States, 15 million in Europe suffer from heart failure, most of which is of ischemic etiology. And in the state of Washington alone, over 2,800 bypass operations and over 13,000 PCIs were performed last year. Just to give you an idea of what we mean by depressed low ejection fraction, basically there are various definitions, but by and large, ejection fraction of less than 35% is regarded as low EF. And we're seeing a trend towards more survivors and seeing more of these patients in a clinical practice, most likely because of improvement in recognition and early diagnosis and better medical management of these patients, the aging population, and the prevalence of obesity and diabetes in our populations in the Western world. So the modes of therapy, by and large, include bypass surgery, PCI, and of course, in patients with advanced heart failure, heart transplantation is gold standard, as well as durable mechanical circulatory support, which my colleague, Dr. Keenan, will be speaking about in the next talk, so I won't dwell on those. But really the holy grail of low ejection fraction revascularization probably pertains to myocardial viability assessment, which is a very controversial topic, and the evidence for which is developing. Just to review the evidence for low ejection fraction bypass surgery, was studied extensively in one randomized controlled trial, which was in the early 2000s, and looked at looked at bypass surgery in combination with best medical therapy versus best medical therapy alone. And the conclusion was that after 2 years, bypass surgery and best medical therapy conferred the best prognosis for these patients, and that reached statistical significance. However, what this study did not demonstrate, or was not able to demonstrate, was the correlation between myocardial viability, in other words, portions of the myocardium that are hibernating and are not infarcted, and prognosis in this cohort of patients. Evidence for PCI for low EF is even more lacking. There are 2 studies that were performed that looked at high-risk PCI, and many of whom were surgical turndowns, and looked at performing PCI in patients with mechanical support, comparing intra-aortic balloon pump and Impella as mechanical support for these patients. And in a sense, these 2 trials indirectly correlated their survival, the 6-month survivals, with the STITCH trial that I just spoke about, with the surgical arm of the STITCH trial, and they claimed some equipoise Having said that, it was by no means a direct comparison. So myocardial viability. So again, evidence for myocardial viability is unfortunately lacking. There were a couple of studies that were performed again in the early 2000s. One was by Kim et al. And I put their graph on the right side of the screen. And they basically demonstrated that with cardiac MRI and with delayed gadolinium enhancement reduction, there was basically improved myocardial contractility in these cohort of patients, and those cohort of patients significantly benefited from revascularization. This was followed after 2 years by a meta-analysis of a pool of over 3,000 patients who were assessed with thallium PET and dobutamine echo. And this meta-analysis actually revealed significant benefit for patients on having myocardial viability and getting revascularization. Interestingly, this meta-analysis revealed no survival advantage for patients undergoing revascularization if they did not have viability. And this was, of course, refuted by the STITCH trial, who demonstrated that any patient with a low EF would have survival advantage undergoing revascularization, surgical revascularization. So how do we go about assessing these patients when we get referred? So basically, it's a multidisciplinary approach involving us as cardiac surgeons, interventional cardiology, and heart failure cardiology. All these services are consulted. And as I discussed, although the evidence of viability is lacking in terms of prognosis, it definitely is an indispensable tool for us in determining myocardial viability, and turns our focus to those areas in particular that need a great deal of attention and time for us to make sure that we restore blood supply to that portion of the myocardium. Again, the evidence for right heart catheterization is rather patchy as well, but by and large, if patients are admitted with low cardiac index, it would indicate to us that their end organs are at potential risk and we need to move forward with a revascularization strategy sooner rather than later. And of course, we work these patients up for surgery and PCI with our standard investigations, including CT scan, vein mapping, and carotid duplexes. So pre-procedurally, we tend to optimize these patients by admitting them under heart failure cardiology, achieving euvolemia just to reduce the stress on the myocytes by decompressing the ventricles, assuring that we have adequate perfusion to the end organs pharmacologically by means of inotropic support or mechanical support, such as balloon pump, Impella, tandem heart. There are various mechanical circuitry support options that we have. We frequently consult our electrophysiology colleagues for consideration for implantable cardioverter defibrillators in these patients. As you all know, that low ejection fraction does predispose patients to ventricular arrhythmias. So as I alluded to earlier, by and large, for low ejection fraction coronary disease, provided that the patients are reasonable surgical candidates, we do tend to offer surgery with the aforementioned workup. And in patients who are not fit enough for surgery or are deemed very high risk or are rather unstable, we pursue the PCI route. There are also hybrid approaches in cases where, for example, the patient is unable to withstand a long cross-clamp time, or if there's a porcelain aorta, we can undertake the main anastomosis to the left anterior descending artery and perform the remainder of the revascularization through a percutaneous approach. Post-procedure optimization would include a follow-up by heart failure cardiology, and as I alluded to earlier, really the benefits of low ejection fraction revascularization, according to the STITCH trial, was seen after 2 years. It's absolutely imperative that heart failure cardiology follows these patients with goal-directed medical therapy and serial echocardiograms to ensure reverse remodeling of the myocardium moving forward. Really the ambition here is establishing a regional service, and we are already receiving plenty of patients from other states for this therapy, given that we have all the infrastructure here to be able to support these patients. Since last year, we've established a coronary cath conference, which is a weekly virtual conference every Thursday at 7 a.m. and everybody's welcome to join. And this is really a forum for any referrers from within the state of Washington and beyond to be able to refer patients. And of course, our outreach team have been great in promoting us. So here's a flow chart of what we're really looking at in terms of management of these patients, just to simplify things for our referral source. This is really what I wanted to talk about. So, and what I have talked about and summarized already in this slide. So that's the end of my talk, and thank you very much for your attention.